National Capacity Building Program on Patient Safety in India. And this is a webinar series for those participants who have newly joined to the webinar. This is a national webinar series with an attempt to enhance knowledge on patient safety, the different issues or aspects of patient safety with the medical and dental colleges in the country. And we are doing two webinars in 1 month. Every fortnight, we do a webinar. And today, primarily, we shall be discussing on surgical errors. We have two esteemed speakers, Dr. S. Siddharth Rao, who is the additional professor and HOD Department of General Surgery at AIIMS BB Nagar. Then we are Then we have Dr. S. Kalyani Surya Dhanalakshmi, additional professor and HOD Department of Anesthesia, AIIMS BB Nagar. And both the speakers, they shall be discussing on the topics prevention of pre and post operative surgical errors and prevention of intraoperative surgical errors. So I think Avdeji, sir has not joined till now. Maybe we can request the speakers to start, I think.
Sure, sir. Yeah, sir has joined actually.
Yeah. Avinash, can
Welcome.
you hear us?
Yes, sir, you are audible.
Yeah, yeah.
I would like to request Dr. L. Swasthacharyan sir, who is also heading the Patient Safety Secretariat at the Directorate General of Health Services, Ministry of Health and Family Welfare, to kindly guide us through for the welcome remarks, sir. Over to you, sir.
Thank you, Avinash, and greetings from the Patient Safety Secretariat here at DGHS to all our members who have joined here. Many of you are from the AIIMS Patient Safety Nodal Officers Group, Patient Safety Nodal Officers Group from the medical colleges, hospitals, residents, nurses, and other healthcare professionals. First of all, a very happy New Year to each one of you. So we hope that this New Year bring us health, prosperity, renewed dedication to our shared mission of providing quality care and set high standards of patient safety across healthcare institutions. That's how we start our new year. And as a part of the national webinar series to develop capacity for patient safety, today's topic is very, very interesting. It's on the prevention and management of surgical errors. And those of you who have read the book, what is known as Checklist Manifesto by Atul Gawande, many of you will know that patient safety, the whole concept of patient safety started with surgical safety, and we moved on to include many of the other pillars of patient safety as we go along. So that book, if you happen to read that, you will understand why patient safety is very, very important. Many of us have also gone through our own grinds in the medical colleges, and we must also realize that in the operation theaters we have got speakers who are surgeons and anesthetists who are the speakers here. Sometimes when you go walk into the operation theater, many of the senior surgeons know the seniors anesthetists, but many of the junior surgeons doesn't even know the name of the anesthetists with whom they are operating. Forget about the nurse who is going to be there in that group. So that kind of situation still exists, not because of neglect, but because that we still do not have a checklist of maintaining a culture inside the operation theater. So thereby, the prevention and management of surgical errors are very, very vital to enhancing patient safety and ensuring better healthcare outcomes, given the significant global burden they impose. And unsafe surgical practices are often stated to lead to complications to about 25% of the patients, affecting nearly 7 million individuals per year. So this number is very huge, the burden is high, and these are all preventable errors. And so therefore, friends, colleagues, and ladies and gentlemen, effective prevention strategies should therefore include comprehensive pre-operative planning. And to make it very simple, a simple hi, hello, what's your name? How long are you here in this hospital? Is this your first operation? Is this your second operation? Or how long have you been posted in this in this department? Kind of introduction is very very required in the operation theater. Meticulous attention to the surgical techniques as per a checklist by the whole team, not just the surgeon, not just the anesthetist, but the team consisting of the staff, nurses, etc. is very important. We are trying to build a culture of safety that emphasizes teamwork, open communication, and ongoing education for healthcare professionals, which is very, very essential. So with this, Dr. Avinash has already identified and introduced the speakers. We are happy that despite their busy schedule, we have Dr. S. Siddharth Rao, additional professor and head of Department of General Surgery in AIMS Bibinagar, one of the upcoming, very imminent AIMS in Bibinagar, who will be speaking on prevention of pre and post-operative surgical error, which is very, very important. And then Dr. S. Kalyani Suryadhana Lakshmi, additional professor and head of Department of Anesthesia from AIMS Bibinagar. I'm sure the two speakers must have crossed roads, and they must have met each other in the operation theater. And I'm happy that both of them are coming out to to speak to all of us. We are very excited to listen to both the speakers who has wealth of expertise and practical insights to help identify potential surgical risks, implement safety measures, and share knowledge to minimize errors. Our motto of doing no harm to any patient is going to be completed if we observe all of this. So with this, I thank Avinash again and the entire team of the Patient Safety Secretariat here in DGHS for organizing these regular webinars, which is becoming very popular all over in India. As I go on different tours to many medical colleges and the state governments, they often talk about the webinars that we have from our division, particularly for patient safety and NCT program. So I'm excited to listen to both of you, and let us hope we have a very good afternoon today, trying to decipher some of the age-old problems of patient safety. Thank you, and over to you.
Thank you, sir. Thank you for your welcome remarks. Now I request the speaker, Dr. S. Siddharth Rao, sir, to kindly share views on the prevention of pre and post operative surgical errors. Over to you, sir.
Thank you so much, Dr. Ramesh. Dr. Avinash. Thank you so much. I'll start with sharing my presentation. To start with, the patient harm due to medical mistakes can be catastrophic, and it results in high profile consequences for the patients, for the doctors, as well as for the institute. And we know that even a single error can destroy a surgeon's career sometimes. So while mistakes are inherent to human nature, it is becoming more recognized that some mistakes are preventable. Good afternoon, everyone. My name is Dr. Siddharth Rao, and I'm additional professor of general surgery at AIMS Bibinagar. And I will be talking about some of the ways we can prevent surgical errors in pre and post operative periods. So, first, let's start with what is the meaning of medical error. So, the definition, according to Institute of Medicine, the Committee on Quality of Healthcare in US, which performed the first the study on medical errors, defined medical error as an unintended act of either omission or commission, or one that does not achieve its intended outcome, the failure of planned action to be completed as intended, that is error of execution, use of wrong plan to achieve an aim, which is error of planning, and a deviation from process of care, which may or may not cause harm to the patient. To simplify this, Grober in this article defined medical errors as failure in care that may or may not result in patient harm. One thing to be highlighted here is that it's not necessary that the patient is to be harmed for an event to be labeled as an error. So first, do no harm is the fundamental principle of any healthcare service. No one should be harmed in healthcare. However, there is compelling evidence of a huge burden of avoidable patient harm globally across the developed and developing healthcare systems. And this has major human, moral, ethical, and financial implications. Now, as per WHO and other data, around 1 in every 10 patients is harmed in healthcare, and more than 3 million deaths occur annually due to unsafe care. More so in low to middle income countries, as many as 4 in 100 people die from unsafe care. And this data is not specific to surgical errors, but it gives us an overview of the problem that we have to deal with. Now, various articles have reported incidents of death due to medical errors ranging somewhere between 44,000 to 4 lakh per year, which would make deaths due to medical errors the third leading cause of death in the US. Now, although, sorry, potentially preventable surgical error occur very less frequently when compared to medical errors, they have received increasing attention in recent years. Now, this paper by Hempel and colleagues puts the figure of wrong side surgery at 1 event per 1 lakh procedures and retained surgical items at 1 event per 10,000 procedures respectively. So before we go ahead, it's important for us to familiarize ourselves with certain terminologies that are associated with medical and surgical errors. The first being adverse event. This is an event where a patient is injured causing disability or prolonged hospitalization that is caused by medical or surgical management rather than the patient's disease. A near miss event is a medical error that could have resulted in patient harm but did not, either due to timely intervention or by pure chance. So, in fact, a near miss event is an adverse event where there was no harm to the patient. And never event are medical errors that should never happen. For example, surgeries done on the wrong patient, on the wrong site or wrong side of the patient, retained MOPS, etc. Now, the term wrong site surgery refers to any surgical procedure performed on a wrong patient, on a wrong body part, on the wrong side of the body, or at a wrong level of a correctly identified anatomical site. So, in continuation of my previous slide, some examples of preoperative surgical errors are surgery that is done on the wrong patient, on the wrong side of the patient, wrong level or wrong part surgery, wrong consent taken for surgery, arranging for wrong type of blood groups, important blood investigations that should have been done but were not done before surgery. Similarly, post-operative surgical errors may be retained foreign objects, wrong specimen labeling, lost specimen, wrong surgical notes, or wrong post-operative instructions. So the Joint Commission has identified certain factors that contribute to an increased risk of wrong site surgery. And they are when multiple surgeons are involved in a single case, multiple procedures on a single patient during a single event, surgical visit, sorry. Unusual time pressures to start or complete a surgical procedure, and unusual physical characteristics, including but not restricted to morbid obesity or any other physical deformity. Now, there are certain challenges and barriers to improving patient safety by decreasing surgical errors. The first being the traditional culture, especially in the operation theater, which is rife with hierarchy. Intimidation of other OR personnel by surgeons was historically accepted as a norm. So this can prevent nurses and other operating room staff from pointing out potential errors or mistakes. Furthermore, surgeons are less likely to acknowledge their propensity to make mistakes and admit these mistakes if they ever happen to others. And surgeons also tend to minimize the effect of stress on their ability to make decisions. Surgical errors also tend to be more prevalent, underreported, or neglected in an organization that does not value patient safety. And as I said in my previous slide, risk of error is increased where a team of healthcare workers provide care without proper communication. And also lack of awareness about safety protocols to be followed and to whom to report to in case a event does occur, and also fear of blame or retribution if such an event is reported. Now, with this background, we can finally discuss some strategies that can be used to prevent pre and post operative surgical errors. Medicine is considered to be a high risk system with high error rate, but these two may not be always correlated. For example, there are two other industries which are high risk but maintain a very low error rate. The first is the aviation industry, from where we have adapted the system of checklists, crew resource management, safety attitude questionnaires, etc. And the other is the Navy's nuclear submarine program. Now, there are certain aspects in these two industries which we as surgeons must be able to learn, and that is individual ownership, responsibility, attention to detail, professionalism, moral integrity, and mutual respect. Now, safety culture must be a priority for an organization, and this culture must start right at the top and permeate all the way to the bottom. And such organizations that prioritize patient safety usually share these characteristics. That is, acknowledgement of the high risk, error prone nature of our organization's activities, a non punitive environment where individuals are able to report errors or near misses without fear of punishment or retaliation, an expectation of collaboration across ranks to seek solution for vulnerabilities of established institutional systems or institutional protocols, and a willingness on the part of the organization to direct resources to address patient safety concerns. And to measure the impact of all these interventions that they have on safety culture of an organization, one can use safety attitudes questionnaire, which is a validated survey instrument that can be used to measure safety culture in a healthcare setting. Now, this questionnaire gives a score that can be used to audit safety standards within the hospital or among several hospitals. Sorry. It must be quite clear by now that most of the errors are due to miscommunication or a breakdown of communication among healthcare team. Now, communication is crucial throughout the surgical process, particularly during preoperative assessment of the patient. And the method that is most reliable and widely used is the WHO checklist that encompasses operating room briefing and debriefing. The WHO checklist has made this into a structured format that is easy to use and is effective. Now, starting with operating room briefings. Now, when used appropriately, operating room briefings help facilitate transfer of information among team members. A briefing or a checklist is any pre-procedural discussion among the team regarding the type of surgery, site of operation, requirements, needs, and special issues of the surgical process surgery to be done. And these briefings must be locally adapted to specific needs of the specialty. And these have been associated with improved safety culture, including increased awareness of wrong site or wrong procedure errors, early reporting of equipment problems, reduced operational costs, and fewer unexpected delays. OR briefings also ensure evidence-based measures are used, like administration of preoperative antibiotics and DVT prophylaxis. Briefings allow personnel to discuss potential problems before they become near miss or an adverse event. A post-surgery debriefing is discussion among the team members after surgery, and this improves patient safety by allowing for discussion and reflection on the causes of errors or critical incidents that may have occurred during the case. Errors or critical incidents are regarded as learning opportunities and not a cause for punishment. During debriefing, the team can discuss what went well during the case and designate a point person to follow up on any proposed action that result from the discussion. In addition, most debriefs also include verification of sponge, needle, and instrument counts and confirmation of correct labeling of surgical specimen. Finally, sign outs or handovers. These are verbal or written communication regarding the patient's information that is given to the incoming physician or surgeon. Handouts or handovers should occur whenever a patient's healthcare provider changes or the patient's setting changes. For example, sign outs are mandatory when patient is shifted from the ward to the operation theater or vice versa. Studies have shown that this process of handover is unstructured, prone to errors, and many times there is failure to mention active surgical or medical problems, presence of drains, catheters, feeding tubes, etc. And failure to communicate this to the incoming physician or surgeon leads to confusion and uncertainty by the duty surgeon while taking decisions, and this results in delivery of insufficient and suboptimal care. To improve this communication, the use of more structured verbal communication like situational debriefing module or S bar is recommended. Now, this, as we know, is a WHO surgical safety checklist that is widely used to decrease surgical errors. And if we take our attention here down to the last line that says this checklist is not intended to be comprehensive. And this is more of a framework on which many layers of additional variables or information can be added as per the hospital or healthcare's workers as they see fit. Now, finally, as we are all in training institutes, one important aspect of prevention of errors in surgery is to train our students to identify and prevent errors. So during postgraduate training, emphasis is given to surgical skills and decision making. Faculty who are responsible for training next generation of highly qualified surgeons must facilitate delicate balance between resident autonomy and patient safety. And this is achieved by gradual increase in patient responsibility, autonomous decision making, and surgical action by the postgraduates. And a key component to achieving this is by using high fidelity simulators, where a learner can make use of a variety of errors during the course and demonstrate error management as well as options for correction of errors without any patient safety issues. So finally, the take home message in my opinion is that medical errors are a burden on healthcare system. Surgical errors are multifactorial but are preventable, and there must be realization among surgeons that we are human and we must learn to put patients care and safety before our own ego and seek help when required. All team members are equal and everybody should have a voice and an environment where concerns can be raised, and importance of communication cannot be emphasized enough. Thank you so much for your patient listening. Dr. Avnash?
Yes, sir.
Yes, I'm done with my presentation.
Sir,
I'll be happy to
thank you
take
so much.
questions if there are
Sir,
any.
thank you so much. I think we can have the questions in the end.
Okay, right. Thank
Yeah.
you.
So now I invite Dr. S. Kalyani Madam to kindly take over and discuss upon the prevention of intraoperative surgical errors. Over to you, madam.
Good afternoon, everybody. Thank you so much for inviting me over onto this podium to give my views. And so thank you very much. So I'll start off because it's mid-afternoon. Everybody must be a little on the drowsy side. So this is the line of control, and OT is like a little small war ground between the surgeons and anesthetists. We have two different points. Ours is patient's heart and lungs should be beating throughout, and the surgeons are off cutting major organs. So in all this, the common ground being the patient, which I am very proud to say we have the WHO checklist going on in our theaters where this is done wholly and every time the patient enters the theater, and the ownership has been given over to the nursing officers, taking the surgeons and anesthetist out of the game. So both have to listen to the surgical safety checklist at each point. However, the scope of the problem, as you can see, surgeons are major contributors to patient harm. Nearly 8 to 10% of most of the harm is preventable. In this, the human factors are very important. And in saying so, just an overlook as to how dangerous is our healthcare. It's very dangerous. It's as good as bungee jumping or mountain climbing, while our scheduled air flights are not so risky and actually quite safe. So to make our healthcare, which is internationally most dangerous, we have to take several efforts at all levels. So I would like to refer to as a critical care incident or a surgical error or a medical error in which both the anesthetist as well as the surgeon are key players. So in the critical care incidents, I would be, referring to adverse events, errors, medication errors and harms, all on the same, with the same terminology. So surgical errors, obviously, as Dr. Siddharth has already covered, do happen a lot. And if you look at it, in a small study with 5,200 surgeries, 84 deaths which were alluded included 63% which were because of errors in care, which mostly happened during emergencies and had a more of adverse events. So these could be diagnostic errors where actually an appendicectomy could be missed because of various reasons, including non-availability of an ultrasound machine or an X-ray or whatever, or a judgment error where you open an abdomen and it's acute pancreatitis and not and there is a technical error where by mistake an artery or a vessel is a cut. And coming to the omission and commission errors, which we have thankfully come down with the checklists. And then we have the system error and the medication errors. Similarly, anesthesia also plays a critical core in the intraoperative errors. We also, not so proudly, the errors include around 9.35 cases per 1,000 anesthetics, which include both the respiratory and the cardiovascular system. And especially the airway is a big problem because the loss of airway could result in a death between 3 to 5 minutes. So that's very critical. And it can also lead to oxygen desaturation, which do contribute to harm. And cardiovascularly, very commonly, we have hypotension, tachycardia, bradycardia, hypertension, as well as massive hemorrhage due to other causes. However, if you look at it in between anesthesia, 16%, and surgery, 18% of a possible harm, we have 12% which is attributed to human factors and 47% because of the patient himself. When we say patient, obviously a patient with a coronary artery disease or a diabetes of more than 20 years, with autonomic neuropathy, or a patient who's had a massive blood loss, their risk would obviously be more than any other patient, average patient. Similarly, procedural sedation has been associated with a high risk of critical incident because the monitoring is not as high as in a general anesthesia. So as Dr. Siddharth has rightly pointed out, communication, like insufficient preoperative assessment from the patient, from the doctor's side, incorrect interpretation of the patient's state, faulty manipulation technique, miscommunication with the surgical team, all play a critical role in causing these incidents. However, as in a tertiary care center in India, most of the events were preventable. Yes, checklists are done. Mental rehearsal is important, which improve technical skills, but they do not fully account for the non-technical requirements to prevent critical events. So in UK and in other countries, they have non-technical skills for surgeons, which is a separate workshop. And anesthesia non-technical skills, again, a workshop for anesthetists as well as other doctors, so that our communication skills, our leadership skills, we are trained to assess other events. So what does the non-technical skills include? Communication, situational awareness, leadership, and decision making. So the onus is on the team leader to do all the decisions. And as I like to say, communication, further again, like as simple a job as shifting the patient from the operation table onto the trolley. If all 5 personnel do not work on time, the patient does fall down. So yes, clear, concise communication. And that is the anesthesia non-technical skills, where the planning, prioritization, getting everything ready play a key role. I would like to here highlight something called the situational awareness, which is very important. So this is in a situation which is not anticipated, a sudden bleed, an abnormal anatomy, a laparoscopic event where the varus needle hits the vessel instead of going in. So these are where there is a sudden event and we should know how to tackle it. So in this is a high pressure situation, which leads to poor decision making include due to the stress reaction. So either there's a fight or flight or freeze and hide. So what happens? Here again, we learn from our aviation industry where the pilots are trained with the simple threat and error management cognitive aid. So we have to go through the error management situational workshops or simulation workshops where we assess and develop critical events and decision-making capabilities. So no, this is situational awareness. A loss of situational awareness in the OT occurs during crisis. And this leads to tunnel vision, where the first input to go is the auditory. And once you freeze, you don't know what to do. And this increases the error. So they say find a place of safety. So come down, get your core, take a deep breath, and sort the problem out. If there's a bleeding surgical site, put swabs, and then have a team huddle, as I like to say, talk to your colleagues, talk to the anesthetist, and take some inputs as to what should be done. That is patient, procedure, and people. So all these 3 have to go in line. So this mini brief is very important to breaking the stress cycle. So as they say, technology does not increase situational awareness. And you can see people walking on the road, playing games on their phone. So by involving the whole team allows effective communication, and it flattens the team hierarchy where people can they chip in and give their opinions, and it improves their decision making. So this is in brief about patient, procedure, and people. That's at the microscopic view. But however, when you go back to the high reliability organizations like aviation, military, nuclear power, there is a Swiss cheese pattern. They do not look at the final point, which is the unsafe act. They look at where could this act have been prevented? How could we do it? So at the organization level, for medicine, there is the human factor analysis and classification system for healthcare. And they do the root cause analysis. And in this, the organizational influence is key. Like having this webinar shows that we are having patient safety as a priority. So when we have that as mission, patient safety, how all can we improve the, increase the patient safety by having webinars, communication. We have to learn from adverse events. We have an operational process. What is the operation process? Simply setting up the emergency department doesn't help. We need to equip the emergency department. The path to the operation theater should be clear and short. The lifts should be working. There should be adequate wheelchairs and trolleys. All that is in the conceptual stage, including resource management, having the adequate qualified workforce, the technicians, everybody should be educated and having the right training. That's at the conceptual level at the organization. Then the supervisory factors. So getting people in at the right time with the right training is very important. And knowing what the plan is, what is the protocol, and what do we do if there is a supervisory violation when people don't turn up. All these are very important. Preconditions for unsafe acts. We have to understand that the event just doesn't happen. So having the right tools and technology, and if there is a technology failure, what are we going to do? So we have to have good infrastructure as well as a backup for the infrastructure, a physical environment where the lighting, the layout, the noise, the clutter, the workspace design all play a role in reducing unsafe acts, as well as task. So each individual should know what their task is, as in the complexity, the criticality, and the consistency of assigned work. So there should be clear accountability for each task. Individual factors, and this plays a key role. And the government has come up with reducing the working hours for our postgraduates because, yes, too much of work and stress reduces their mental capacity to handle critical events. So mental state, physiological state, and fitness to duty are very important, which play a role in preventing all these errors. As again, it cannot be said often enough, communication is key. Please talk, and talking, coordination, and seeing that the other person understands what you have said. So a closed loop communication is very important. And leadership. So there has to be a team leader who takes ownership of the whole situation if a crisis occurs. So this ownership is very important. And so coming to the unsafe acts, decision errors, yes, identify if the plan is inadequate, try to get more information, sort it out. Skill-based errors, call for help. Perceptual errors, talk to somebody, discuss what could be the other differential diagnosis so that these can be avoided. Violations, routine violations like bending the rules. Everybody comes late and it's accepted. So this could be changed. And exceptional violations, somebody's involved in an accident, he cannot turn up. So we need to have a plan B in place so that the critical works, important works cannot be stopped by putting in a unqualified person to do the qualified work so that the work continues. So this is an overview, systems engineering initiatives. So the work system with the technology, tools, tasks, person, organization, all that is very important. And if these are good, the process where the specialists are doing the right job at the right time for the right patient, and this cases causes a better outcome for all. However, efforts to reduce or eliminate errors, integrating cultural utilization culminate in a high reliability organization, and the healthcare system has to get there. We are in the right process where we have started. The just culture, as Dr. Siddharth has said, that we have to stop judging and blaming. We have to take a feedback, we have to sort out, we have to find out where the error is, and that needs the trust between the whole team so that that error which happened should not be repeated again. So prevention of errors includes preoccupation with failure and never being satisfied. So we have to know, if things, what is my plan B and what is my plan C if this doesn't happen. So we have to keep trying to anticipate what are the potential problems. Resistance to simplifying observations and experience. We can't say ye chalta hai, kuch nahi hoga. No, that doesn't help. So we have to dive below and look for complexity and risk as to where what went wrong. If there was a surgery on the wrong side, was the X-ray display machine working? Was the X-ray put on in the right position, or the whole team plays a role? We have to keep switching and sharing responsibilities and preventing these errors. So engagement of frontline workers, increasing their accountability, and to report any deviation from expected performance because their job is critical in getting the right outcomes. Resilience, and that is so important. The capability to recognize errors quickly and contain them and to cause rapid normalization and improvement, and deference to expertise. So there are times when I feel, I just okay, this is where we are. Is there something we are missing? So that I think we have to be able to open up and talk about without getting the egos into place. So I would like to conclude that if you're unable to understand the cause of a problem, it is impossible to solve it. So we have right now identified a problem, and it is not to do with India or being a developing state. It's a universal problem because there are a lot of humans involved, and integration of all these humans and good communication, continuous improvement, as in training of everybody in the department from the top to the bottom to work as a team is very important, so that we reduce the errors. So thank you, and kudos. Thank you very much.
Thank you, ma'am. Yeah. So I think now we have come to the end of this webinar on surgical errors. And from the Patient Safety Secretariat, we are thankful to the faculty for sharing their views on the topic. So I think, and Avdeshji,
Yes, sir.
I think we have already exceeded the time limit, and maybe questions and all, maybe we can uh, compile and share it later on somewhere on the group or something.
Sure,
And
sir.
also, I would
It
like
is
to mention
possible.
here that the technical support for this webinar, it has been given to us through the ECO platform, and we are thankful to ECO for doing all the groundwork so that we are able to organize this webinar series without any technical glitch. And Mr. Avdesh is always trying
Thank you so
to
much, sir. Thank you
support
for your
us in
kind
whatever
words.
possible way.
Thank you so much, sir.
Yeah, yeah. So thank you, everyone. Avdesh, we can sign up.
Yes,
Sign
sir.
off.
We can
Oh,
wind up the session. Thank you, everyone.
Thank you.
Thank
Thank
you.
you so much for having us.